Now we are focusing on paranasal sinus inflammation, a condition that can include lesion ranging from mild involvement of the paranasal sinuses with inflammation of the mucosa over there, and reach also lesions that are able, like the image you have in front of you, to produce enlargement of the ethmoid cells and displacement of both globes, and you understand that this is a condition that will require a precise evaluation by imaging. But to approach this field, it is important to understand that first of all we are going to fly through the 3D volume using multi-slide CT, the technique that replaced the use of a single slide and permit a reconstruction in several planes of the anatomy and of the structures and of the lesion that will be in this framework, and also the possibility of using three-dimensional MRI. The third point that we will cover is the introduction of cone beam CT in this field, with the advantages of a low dose for the patient at the price or at the advantage of an increased spatial resolution, though the acquisition time is a little bit longer, and therefore patient cooperating is one of the problems to solve. The planes to be used, of course, we are dealing with a three-dimensional structure, and it is important to navigate and fly through this volume in the axial, in the coronal, and in the sagittal plane. Then there are very relevant reference structures that should be a landmark for the surgical approach by means of the endoscopy, and these should be demonstrated by imaging and pointed out in your report. The most frequent inflammatory condition we are going to analyze are basically the acute rhinosinusitis, and when the imaging studies are necessary, the chronic rhinosinusitis with and without polyposis, and less frequent forms like the ones where the aggressive disease is going to destroy the structures of the sinuses, either the mucosa or the bony framework. One key point is anatomy, and anatomy is most of all the anatomy of how the air flows into the nasal cavity, passes through the different and complex arrangement of the ethmoid cells to reach from this anterior position to reach the choana and pass into the upper airway. It is important to note that the structures that are located off the midline are structures that are very important to understand the anatomy. Mostly the fact that the mucus coming from the frontal sinus, from the maxillary sinus, in this case is beyond the inferior and beyond the middle turbinate, and from the posterior cells of the ethmoid sinus and from the sphenoid sinus will empty, the mucus will empty into two different paths. The first one and the most anterior one is the path of the middle meatus, approximately located where you see the asterisk, and this path will drain the mucus coming from the frontal sinus, from the anterior ethmoid cells, from the maxillary sinus. The key structure to separate the anterior from the posterior ethmoid sinus is the one you are seeing there. It is the middle turbinate. The middle turbinate has an horizontal portion and has a lateral attachment. The lateral attachment is obliquely oriented, and then you can see along the red dots that this lateral attachment will reach also the floor of the anterior skull base. It will separate a complex in front of it, that is the complex of the bulla ethmoidalis, made by several cells that are intercommunicating, and the mucus coming from this cell will empty along this very narrow space, which is the semilunar hiatus. That is the space where you have the three asterisks. In front of this complex is another small complex that in simple condition is made up by a single cell, which is called the Agarnase cell, meaning the first and large ethmoid cell located immediately in the first slices you have when you reconstruct in the coronal plane. What is also very important to note is that the path for the drainage of the frontal sinus will pass through this narrow recess that has a shape dictated by the competition between the complex of the cell of the ethmoid bulla and the complex of the cell in front of it, the Agarnase. It can be much more vertical or much more oblique oriented according to the competition and according to the winner of this competition. Behind the ground lamella, the basilar lamella of the middle turbinate is the superior turbinate, and this structure in front of it there is the opening of the posterior ethmoid cell, and behind there is the sphenoid sinus. This is the area where the cells coming from the posterior ethmoid sinus and the mucus coming from the sphenoid sinus will empty in the superior meatus. Therefore, in synthesis, the middle meatus will drain the mucus coming from three different chambers: the anterior ethmoid cell, the frontal sinus, and the middle and the maxillary sinus, whereas the superior meatus will drain the mucus coming from the posterior ethmoid cells, from the sphenoid sinus, and the mucus in both cases will pass through the choana inside the nasopharynx. Therefore, we have two different systems: in violet the anterior one, and in blue the posterior one. And it is very important to notice the fact that we are looking at those structures in the sagittal plane. Why? The sagittal plane is very important, though the coronal one is also very important, but the sagittal plane, for example, will give you this type of information. There are situations in which the competition for the space is won by the posterior ethmoidal cells, but not in the direction, in an anterior direction, also in the posterior direction. In this case, there is a pneumatization, an accessory pneumatization of the sphenoid sinus, resulting in a chamber that is located on top of the sphenoid sinus. Why this is important? Because if you are a surgeon and if you have your endoscope moving in this direction, if you don't know that this is the specific arrangement of that specific patient, you are running a very large risk of thinking that you are going to reach the sphenoid sinus. Instead, you are so close to the floor, of the anterior floor of the scan, or the floor of the anterior skull base. Therefore, you really run the risk of damaging the patient, and particularly if you consider the position in the coronal plane of this variant, which is called the Onodi cell. It is so close to the passage of the optic nerve that one of the risks they are running is the fact that you can damage the optic nerve. Therefore, three different planes can give you the information. One is the sagittal, the other is the coronal, because any horizontal lamina dividing the sphenoid sinus in two different parts is something that you have to check to exclude the presence of the Onodi cells on top of the sphenoid sinus. And of course, on the horizontal plane, you are looking for the continuity of the posterior ethmoidal cells, and if, like in this case, you see that the cells are reaching the sphenoid sinus, this is the reason why you should suspect this condition. The blue line is the one that is cutting approximately in the floor of the central, of the anterior skull base. That is, at the same time, the roof of the nasal fossa. Strictly speaking, we have a central lamina that is the perpendicular plate of the ethmoid. We have an intermediate lamina, which is the vertical lamella of the middle turbinate, and we have a much more thinner lamina located laterally, which accounts for the wall of the orbit. It is so thin that usually it is called the lamina papyracea. These three vertical lamina have also a central horizontal very thin lamina that you see is cribrated by several small holes giving passage to the olfactory phyla, and therefore this is the floor of the anterior skull base, and this is the area where you will have the olfactory bulb and the olfactory tract. In green you see the representation of a much thicker bone, which is corresponding, as you can see, to the bone of the frontal sinus. Therefore, if you look at the anatomy at this level, you see on the CT image the perpendicular plate, you see the horizontal portion of the cribriform plate, the vertical portion of the cribriform plate, and then a thicker bone, which is actually the frontal bone. This is the central lamina, the intermediate lamina that giving also attachment to the horizontal portion of the middle turbinate, and laterally you will have the lamina papyracea. It is also important to see that from the maxillary sinus, the cilia will act and actively move the mucus with the movement of the cilia along a very specific path. The path is pointing toward this area. This area is the ostium of the sinus, and from the ostium of the sinus, the mucus will follow a very narrow path, which is the infundibulum, and the infundibulum is dictated by the bulla, its floor, and by the uncinate process. And this is the key to understand how the mucus will be removed from the maxillary sinus. It is important to reconstruct the images in the coronal planes. Therefore, coming from the anterior part, you will see the anterior portion of the middle turbinate, and again we have the central lamina, the intermediate lamina, the middle turbinate, and then we have the uncinate process. Its vertical process is going to attach very close to the vertical lamina of the middle turbinate. Why this is so important? Because in this case, if you look at the frontal sinus, the mucus coming from the frontal sinus will pass necessarily medial to the horizontal, to the vertical process of the uncinate. If you step a little bit behind, you start to see that the infundibulo is narrowed by the presence of a variation, which is the infraorbital ethmoid cells, and going again posteriorly, we are in the central portion of the nasoethmoidal cavity we already discussed. The upper part of the central lamina is the crista galli, that is located at that level. In this case, the crista galli has a component of spongiotic tissue inside. Moving backward again, we see that now the turbinate are three: the inferior turbinate, the middle turbinate, and the superior turbinate. And also we note that the turbinates are larger on the right side if compared to the left side. This is just a simple temporary situation because the turbinate undergo a cyclic variant. Therefore, this cycle is the one where the right side of the nasal fossa and the ethmoid will be used with the vasodilatation of all this soft tissue to provide much more thermal change for the air that will pass through, and also humidification. Then when this cycle is going to stop, the left side will start to work. If we move posteriorly, we see the narrow level of the cribriform plate, and we see this passage between the vertical portion of the cribriform plate and the thick level of the frontal sinus. This roof of the ethmoid is called fovea ethmoidalis. Therefore, fovea ethmoidalis is thicker and belongs to the frontal sinus, whereas the cells are belonging to the ethmoid complex. We are passing into the posterior ethmoid, and the passage on the coronal plane is made up by the fact that you have the lateral attachment of the ground lamella of the middle turbinate. Therefore, now we are inside the posterior ethmoidal cell. And in some cases, like this one, it is possible also to see the supreme turbinate, a fourth turbinate over there. Well, this is the anatomy, and then we are starting with the pathology in this field. Acute rhinosinusitis is the first topic we are addressing. Clinically speaking, this is a condition in which, from a common cold, we have not a relief of the symptom, but instead worsening of the symptoms that will last at least 5 days and persist until 10 days, a length inferior to 12 weeks, and this is a time threshold to detect and to classify this condition as an acute rhinosinusitis. They usually just deserve and require the use of anti-inflammatory and drugs. Imaging is indicated only in special condition. Though imaging is able to show the anatomy even in this condition, imaging will be used when you have a worsening of the clinical findings, you have unilateral signs and symptoms that are progressing, and particularly you have the suspicion of complication in an immunocompromised patient or complication that are related to the possible spread of the inflammation and superinfection to the orbit or to the intracranial content. The complication of acute rhinosinusitis involving the orbit pass through a progression of possible different grades, from the edema of the eyelid to the cellulitis of the orbit to a preseptal abscess, and this is the anterior compartment of the orbit, and therefore the infection could be limited to this compartment, or the infection can spread in the postseptal, coming also from the ethmoid and spreading at least at first below the periosteal lining of the orbit, which is a structure that prevents the invasion of the orbit from infection but also from tumor. Once the structure has been destroyed, that the lesion can spread inside the orbit and produce an extraconal or an intraconal abscess. The more advanced condition is the one when you have the spread of the infection causing thrombosis of the cavernous sinus. Therefore, the cartoon is showing preseptal, is showing again preseptal, and it is also showing the passage from the ethmoid contained by the periosteal lining or the cellulitis, and the final condition that could be reached in some cases, which is the cavernous sinus spread. CT with contrast agent will be used to evaluate, to assess, and to confirm the grade of the complication. You see that it is confined lesion to the preseptal area, or the lesion, like in this situation, is spreading through the ethmoid and it is displacing the periosteal lining, therefore producing a subperiosteal abscess. And patient like this undergone to a decompression by meaning of the endoscopic approach of a situation, but you still have the infection spreading inside the orbit. The fact that the ethmoid is connected by several veins to the intracranial content, and those veins do not have a valve, can explain the fact that we can have a complication like the meningitis, like the epidural abscess, like in this case, with also fluid connection and enhancement of the dura, and also a further complication, which is the intracerebral abscess, like in this case. Of course, as I already mentioned, in all these cases, imaging is very important, and in any condition, CT should be done with the use of contrast agent. There are also different conditions in particular situation. One is the pediatric patient, and this pediatric patient, there is not only the spread in the anterior compartment, as you can easily see from the picture, but also an abscess that can be very precisely delineated by the MRI after contrast agent in injection. Fluid and enhancement, rim enhancement, suggesting the collection of the fluid, something that can be drainage. And in this case, you have a situation in which sudden amaurosis, bilateral amaurosis, and blindness was present in this patient. This is a complication of the accumulation of fluid inside a cavity, like the sphenoid sinus in this case, producing progressive enlargement of the cavity, mucocele, that can also undergo to infection, and this is a mucopyocele. And on the left, there is even a more infrequent condition. Patient is immunocompromised because of leukemia and because of treatment, and in this case, the possible infection by means of the fungal disease will result in ischemia of several tissue, because the Ife will enter the small vessel producing ischemia and gangrenous changes in the tissue. Therefore, when you inject gadolinium, you see a very well demarcated and separated area where you have no vascular enhancement, and this is corresponding to the gangrenous changes of those tissue. Therefore, the role of imaging in the situation of acute rhinosinusitis is to provide key information for decision making. One is to identify cellulitis. Antibiotic therapy is necessary and no surgical approach. Collection, surgical approach is possible. Erosion of the boundaries for a complication, like in this case, therefore acute complication with osteomyelitis, and the differential diagnosis, like in the previous case, from the acute fulminant mycosis or other aggressive granulomatous disease like the Wegener glomatosis, but even malignancies that can mimic a situation with extensive destruction of the tissue. Osteomyelitis is very important, and as we saw in the patient with sudden blindness, the possible complication of a mucocele. Contrast agent should be used. The delay usually is something like between 80 and 90 seconds, and the rate of injection is around 2.5 millimeter per second. This use of CT is indicated in acute complicated rhinosinusitis, but also is indicated in neoplasms if you are not in the condition to use MRI, because MRI in this special setting is better than CT. Aggressive inflammatory disease will also require the use of contrast agent. The second topic is the one related to the chronic rhinosinusitis. This is a condition that is identified by the persistence of the symptoms greater than 12 weeks, therefore some months, and associated with the presence of two or more of the following symptoms, like the mucopurulent nasal drainage, obstruction, facial pain, particularly when there is pressure on particular point, like the one of the infraorbital nerve exiting the inferior rim of the orbit, or hypo or dysosmia. And also this condition should be documented by one or more of the following conditions: the presence of purulent mucus in the middle meatus or edematous at this level, the presence of changes in the mucosa that will increase in thickness and will increase in length, giving and making the presence of several small polyps that are related to the increased length and increased thickening of the mucosa. This will also a situation that will result in polyposis associated with this type of chronic rhinosinusitis. Imaging is another very important point, and as you can see, it is inside the definition of the disease. It is possible to correlate the findings that are demonstrated by CT score with the symptom of the patient, but this correlation is a little bit poor, and a score has been developed, and this is the Lund-Mackay score. If you see, the score can be very sensitive, but then it is low specific. If you increase the requirement of opacification of more cavities or more extensive opacification demonstrated by imaging, you will increase a little bit the specificity, but again, you will lose something in the sensitivity, even if the score is working quite well for the pediatric patient, and this is a very good situation. Pediatric patient, this is a pediatric patient, and this patient already had low-dose CT, but in this case, as you can see, this situation did not improve, and the patient is now showing right proptosis with displacement of the globe on the right side, as you can see, and this is related to the fact that both the anterior and posterior ethmoid cells on both sides are filled by some material that on this turbospin echo T2 will show mostly hypointense signal on this sequence, even if you can see that this hypointense signal is separated from the walls of the cell, but by some hyperintense signal, suggesting the presence of the mucosa and a content that shows very low signal. Why very low signal on a turbospin echo T2? This is a condition in which you can have a fluid that shows progressive inspission, losing water, and having much more protein content, therefore changing the properties of the magnetic properties of this fluid, which is much more similar to toothpaste rather than to fluid. And why this patient has such a condition? You see that the reason was that the cilia in the ethmoid cell, but also in the maxillary sinus, were not able to move properly, therefore were not able and are not able to remove the mucus. The mucus will accumulate there, accounting for the progressive enlargement of the cells. And this is a condition well known. The condition is the primary ciliary dyskinesia, and also does not stop in the ethmoid or the nasoethmoid area, but also, as you well know, it is a condition affecting the bronchial tree and accounting for bronchiectasis, for example. Chronic rhinosinusitis without or with nasal polyposis or without nasal polyposis is a multifactorial condition where several different factors will account for the development of this type of condition. It is very important to know them. On the bottom line, there is also something that can be demonstrated only by imaging. It is the specific related to the patient anatomy of the sinonasal cavity. And this anatomy of the sinonasal cavity can be demonstrated by CT or by high-resolution cone-beam CT. The indication to imaging CT, high quality, and high quality cone-beam CT is when you are dealing with a patient who is resistant to medical treatment, when you're dealing with a patient where there is associated to the chronic rhinosinusitis of a massive polyposis, where you are planning surgical treatment because you want to know precisely what is the specific framework of the sinonasal cavity in order to prevent damage using the endoscopic approach. And of course, it's very important the immunocompromised patient or when looking for or assessing the grade of complication like in the acute rhinosinusitis. This is a patient who already had been treated because of a situation that at the end resulted in infection of the frontal sinus. As you can see, looking at the different profile in the frontal sinus and frontal bone of this patient, the approach was an infrequent approach. It was not an endoscopic approach. In this case, it was an open approach. You can also see the metallic finding over there. And the patient did not recover, but presented worsening of the symptoms. As you can see, there is filling of the supraorbital ethmoid cell. This is the supraorbital ethmoid cell and the residual cavity. Therefore, the patient, for this enlarging chambers that are not healing after the approach had MRI. And this is the MRI that was done in my department. As you can see, there is enlargement of the supraorbital remote cell filled by a signal that is consistent with a mucocele, but then you are looking at something that is very low intensity at this level. That could explain the fact that you have a chronic blockage of the drainage from the frontal sinus and from the anterior ethmoidal cells, but not a chronic blockage of the of the maxillary sinus. If you review the study done in another hospital, you understand that you are dealing with something that has not been correctly reported, and this is an osteoma that is growing, preventing the drainage from the frontal sinus and from the anterior ethmoidal cells. So this is actually the cause for the chronic retention of the mucus at that level. This should not be missed by imaging. Imaging of chronic rhinosinusitis, the methodology is number one. You should know which findings should be interpreted in the perspective of the functional anatomy. Like we discussed before, frontal sinus is blocked. You have to look for the drainage and the path of drainage. The frontal sinus is this, and you're looking from the frontal recess, the orange path. And this schematic anatomic approach is based on two drainage pathways. The anterior, you know very well, is the yellow point, and the yellow point is the final area for the drainage of the frontal sinus, orange, from the drainage from the maxillary sinus, blue, and from the drainage from the complex of the bulla and the anterior ethmoidal cells, which is green. The second path is the path for the superior meatus, and this can be better analyzed in the axial plane. And as you can see from the arrow, the drainage from the sphenoid sinus is passing through the sphenoethmoidal recess to reach this area where you have the superior meatus, and the posterior ethmoidal cell will also empty at this level. Therefore, you know you have to look for one pathway in mostly in the coronal plane and the other one in the axial plane. And the checklist, you have always to check why the mucus is not emptying from that particular group of sinonasal cavities. Therefore, imaging of the chronic rhinosinusitis is related to the detection of the impairment of the mucus clearance through the drainage pathway. You are looking for the anatomic variant that may incite the rhinosinusitis or raise the risk of endoscopic surgery. What does it mean, incite? If you have, because of the particular anatomy, a very narrow corridor through which the mucus should pass, if you have only a mild inflammation, you have a situation in which there is a much more easy condition that any cold could hamper the emptying of the mucus from that cavity. We can use multi-slide CT, low dose, high quality cone beam. These are the most suitable technique for this task. Low dose is very important because most patients are young, and you have to report either multi-slide CT or high quality cone beam CT in a centripetal fashion in the coronal plane, from the center, the nasal septum, and then the respective drainage pathway, the middle meatus, and then the superior meatus, going from this central key point to the periphery. Of course, in this checklist, both soft tissue and bone changes should be reported. This is a comparison between CT and the high-resolution cone beam CT. Patient in this solution is lying supine, therefore the chance of having movement is less relevant than being in a sitting position, but the acquisition time, it is greater than the time required for CT. Few seconds for CT, at least 30 seconds for the high-resolution technique, though the exposure time is something like 2 or 3 seconds. But the advantage of the cone beam CT is mostly detectable when you are comparing, like in this situation, this is a specimen, the reconstruction in the coronal plane from CT with the reconstruction in the coronal plane with the cone beam CT, because the flat panel gives you the advantage of detecting very precisely the structure that run in the horizontal plane that are very difficult to reconstruct with the CT. Therefore, this small channel, which is the channel for the anterior ethmoid artery, can be better demonstrated with this technique. And also reconstructing with a cone beam CT, you can detect in all cases the anterior ethmoidal artery channel, but also the posterior ethmoidal artery channel can be demonstrated. Which patterns are we looking using CT in this patient? We can simplify the situation in 5 patterns. The infundibular, where the mucosa in the infundibule is abnormal. The osteometal complex, where the middle meatus is involved. The sphenoid model recess, where the superior meatus is involved, and other 2 different conditions where we have a sporadic presence of increased thickened mucosa, or we have a complication that is the increased lengthening of the mucosa that will assume a polypoid appearance. The key point is that using the endoscopy and this type of surgery is aimed to remove the condition that impair the mucociliary drainage. And this is a surgery that will remove all this condition, leaving part of the structures there. Therefore, it is not a demolitive process. First pattern, maybe one of the most frequent, is the infundibular pattern, where the infundibular, as you can see, is narrowed because we have a variant in the anatomy, the infraorbital ethmoid cell, and then we have thickening of the mucosa at that level. That is the situation that justify the presence of the fluid inside the maxillary sinus, and then also thickening of the walls can be detected, and this is a finding suggesting chronic inflammation. Also, cone beam CT can be very useful for this task. You can see that in a condition that can be nominated recurrent acute rhinosinusitis, in the sense that several episodes of acute rhinosinusitis are present in some patients. In this condition, you see perfectly the ostium and then the infundibulum, and then the infundibulum emptying in the aganasi cell, and then you see that the size and the passage is hampered by the presence on both sides of the infraorbital ethmoidal cells. When the osteometal complex is blocked by the thickening of the mucosa, then you can have simultaneous 3 different sinonasal cavity filled by mucus: the maxillary sinus, the frontal sinus, and then the anterior ethmoidal sinus. In this case, of course, you are looking at the common path, which is the middle meatus, and you see that also at that level the mucosa is thickened. This is the sphenoethmoidal recess pattern. You see that in that case the mucosa is thickened at the level of the common path in the superior meatus and the common path for the posterior ethmoidal cells and the sphenoid sinus. Whereas the sporadic pattern is something where you have retention cysts, like in this case, that should not be confused and mistaken for this condition, because in this condition you have the lesion that is composed by fluid, but it is a lesion related to the root of this molar tooth, and you see that the wall, the floor of the maxillary sinus has been raised by the progressive increase in size of this cyst related to chronic infection of the tooth. Therefore, if we look at the different tasks of imaging, number 1 will be confirm the clinical suspicion. In case of frontal headache, yes, there is a a chronic situation in which we have, for that patient, a unilateral involvement of the sinonasal cavity. We can have a condition that is called the antrochoanal polyp, in which the retention cyst is also passing through the infundibulum or another part of the maxillary sinus and reach the choana. So it will block the passage of the airway. Or we can have an odontogenic sinusitis, like in this condition where you have fluid and inflammation, and this inflammation will spread through the bone and through the periosteal lining and provoke inflammation also of the maxillary sinus. And then this is a different condition in which this metallic content is something suggesting that you have a situation in which the fungi that normally are there are growing, and they create a very large ball that is called the fungus ball. So this is task number 1. Fungus ball. What is a fungus ball? Fungus ball is probably related to the passage of dental sealers into the maxillary sinus, and this inflammation and necrosis of the mucosa is something that will be an aid for the progressive growth of the mucosa, of the fungus inside the maxillary sinus. And you can see that there also expansion of the walls of the maxillary sinus, like the medial wall, which is the weakest one. What is important for imaging is that, number 1, the fungus ball will not invade the mucosa. Therefore, always you will see that the fungus ball, which is hypo on T1 but also hypo on T2, will be separated from the mucosal lining the maxillary sinus by the mucosa itself, thickened in most cases. And as this is a chronic inflammation, there will be thickening of the bony walls, like in this situation. Therefore, on T1, you will have, after gadolinium, enhancement of the mucosa, no enhancement of the fungus ball. On T2, you will have signal void. This is not air. This is not air like in the maxillary sinus. On the opposite side, this is the fungus ball. You see, you can compare the situation with the T1, and so you are very clearly this is not air. And the mucosa on the T2 with the sequence is hyperintense. Task number 2 is to identify the factors that will compromise the drainage, like inflammation or variants, hyperplasia of the mucosa at the level of the osteometal complex, the presence of septal crest like this one, or the presence of changes in the anatomy like the paradoxical bending of the horizontal portion of the middle turbinate like in this case, or the presence of additional cells inside the frontal sinus that could prevent a normal drainage from the sinus inside the middle meatus. So this is very important. And this is the checklist of all those different conditions. Task number 3 is to assess the extent of the disease. Isolated inflammation of the osteometal complex, because this is a pre-chamber area, very important, common drainage for the 3 chambers, the involvement of the anterior or the posterior compartment, or a condition in which you have a pansinusitis with or without polyposis. Therefore, isolate the condition, involvement of the common pathway, which is the osteometal complex, the pre-chamber is this, and CT and occasionally MRI, a situation in which the mucosa is so enlarged, so thickened that you have the mucosa filling every space available and also able to remodel the lamina papyracea that is no more bending toward the ethmoidal complex, but the curvature is convex toward the orbital content. And you see that you have edema of this mucosa, a very difficult chronic situation that is difficult mostly to deal with from the surgical point of view. Task number 4 is to identify conditions that represent variant at risk for surgery, like the interruption of bony surfaces, Like in this case, within the sphenoid sinus, we have a fungus ball that is high signal intensity on CT, surrounded by the mucosa, low density, but there is erosion of the bone. And this is a situation where you have a weakened point, that can be a very difficult situation for the surgical approach. There also a situation like this, where the content inside the cells are modifying the lamina papyracea, therefore the risk is for the orbit. Or, like in this situation, you have a variant of the anatomy. You look, the fat tissue inside the orbit is prolapsing into the ethmoid, very well separated by this very thin lamina, but if you're going there with the endoscope, there is a high risk. And imaging task number 5, identify the complication, the iatrogenic complication, or those secondary to rhinosinusitis. For example, the osteitis of the maxillary sinus wall, like in this situation, the possible erosion of the heart palate and of the floor of the maxillary sinus, the accumulation of fluid inside the ethmoidal cells, and progressive accumulation will account for the presence of a mucocele with remodeling of the anterior cranial fossa floor and remodeling of the lamina papyracea, but also osteomyelitis. And finally, imaging after microendoscopic surgery. Imaging is very important if the symptoms will not disappear. And if you have a situation like this with major symptoms and a positive endoscopy and a new revision is planned, some of the landmarks will not be there. Therefore, imaging is done to have the landmarks and to evaluate the presence of possible complication. There, in this situation, you have osteitis with a double thickening of the floor of the maxillary sinus, and you have blockage of the mucosa because the polyposis on both sides of the ethmoid. In this other situation, there was a synechia between the residual middle turbinate with the medial wall of the orbit. Therefore, the drainage from the frontal sinus was not possible, and you have a mucocele. Mucocele will erode the walls. Therefore, you can have a complication either in the direction of the intracranial content and in the direction of the orbital content. And like a situation like this, in which on both sides you have, or you had before, mucocele with progressive resorption of the sinusal wall, and this can be demonstrated by imaging. Osteitis not healing at the level of the sphenoid sinus is a very critical condition. And in this condition, you can see the difference in the density that is demonstrated by use of Combin CT. Therefore, osteitis and the changes in the pterygoid process. Yellow arrow is pointing toward the second branch of the trigeminal nerve, and this will account for the persistent headache of the patient after endonasal surgery for a fungus ball. And still we have accumulation of fluid, but not fungus ball. This is hypo on T2, but it is hyper on T1. Therefore, it is not a fungus ball. And where on the Combin CT you don't see any bone, you see that the bone is still there looking at MRI. Because even if you don't see the mineral content because of the resorption, you see the periosteal lining. To sum up, CT is the basis for confirming the diagnosis. CT is very important for evaluating the complicated chronic rhinosinusitis. A careful analysis is very important. The checklist will include the site, the density, the bone changes, and then it is important to discriminate, particularly when you have unilateral nasal obstruction, chronic rhinosinusitis from neoplasm. And the dose issue is very important. For this reason, CT can be replaced by high-quality Combin CT that will provide a dose that is in the 10th of the dose that you can have with a standard Combin CT, of the standard CT. Well, now we move and we analyze two cases. The case number 1 is a male smoker complaining of pain, the possible dental origin. Pain is persisting after the extraction of 28 and 38. Topography of pain is also consistent with the sensory distribution of the maxillary nerve V2. Therefore, a dental scan is obtained. You can look at the dental scan and you see that this reconstruction will show that the floor of the maxillary sinus is not normal. And also in the dental scan, irregularity of the walls of the maxillary sinus are detected, and the fat sac that is located behind the posterolateral wall of the sinus is thickened. For this reason, the patient had, by this dentist, again another extraction. We can discuss about this. The pain does not stop, and a multislicity is obtained in this case. The question is, if you look at the plane in the axial, in the low level, high level, and the coronal plane, the question is which one or which combination of planes will account and justify the patient's symptoms, in your opinion? Is it the axial, low level, where we are at the level of the maxillary sinus? Is it the ethmoid sinus level, or it is the coronal plane? I think that the most important is the axial plane. Why? We have to check, but mostly because of the change in the soft tissue behind the posterolateral maxillary sinus wall, and also because of the thickening and a more sclerotic change in the pterygoid process root, as you can see at this level. Endoscopic surgery is planned, preoperative chest x-rays is obtained, and you can see we have an opacity over there in the apex of the left lung, upper lobe, and also with some transparency inside suggesting excavation. Therefore, the patient had bronchoscopy, had cytology, biopsy, and cultural examination, serologic assessment, endoscopy, showing the presence of endoscopy of the sinonasal cavity, showing the presence of all inflammatory changes. Osteitis was present, and the bronchial biopsy demonstrated with the histology a lung adenocarcinoma. Therefore, you start thinking, well, this could be a metastasis. After this examination and the endoscopic procedure, the patient had worsening of the facial pain and the onset of diplopia. For this reason, we obtain an MRI. Then you have turbospin echo T2 and T1 post-contrast. And the question is, where do you locate the abnormal changes? In the petrous apex and parapharyngeal space, and the parapharyngeal space and pterygopalatine fossa, and the masticatory space and pterygopalatine fossa. So you have to check all these spaces and to understand where we can locate the findings that can explain clearly why the patient is showing this type of symptomatology. I think that the better situation and the better explanation in this case is that we are dealing with a condition where the masticatory space and the pterygopalatine fossa are abnormal. The abnormality, as you can see, is there behind the posterior wall of the maxillary sinus. You have to compare with the opposite side where we have fat tissue and small dots that suggest the presence of the sphenopalatine artery, hypointensity on T2, hypointensity of the bone, mild and non-homogeneous enhancement reaching the pterygopalatine fossa. Because at this level here we have the very important structure that we have to consider. The other point is also the orbit involved? This is easy. You can see that the hypointensity is transgressing the lining of the orbital wall. Therefore, I agree with you in this case very clearly. The fat tissue has been changed, and there is a thickening of the lining of the orbit at that level, also involving this rounded structure. And because the patient is showing symptomatology related to the maxillary nerve, do you see any abnormality of the trigeminal nerve branches? Looking at these three axial planes, the abnormality are present, therefore you will check yes, but yes, the ophthalmic and maxillary, yes only for the maxillary, yes for the mandibular branch, or no. I think we were discussing the fact that there was thickening at the level of the posterior wall, the maxillary sinus, and also at the level of the pterygopalatine fossa. We are dealing with a condition in which there is the involvement of the infraorbital nerve, which is passing along this groove that is the infraorbital groove, and then moving with the bayonet straight, bending straight toward the maxillary, toward the level of the foramen rotundum, and that is the Meckel cave. If you look at the bayonet course of the nerve, it will end at this level in front of the Meckel cave, whereas this small and narrow channel is the one for the Vidian canal. Also, the rounded structure, which is the infraorbital canal, has been involved. Therefore, our diagnosis should take into consideration why the patient had this situation. Are we dealing with a chronic rhinosinusitis with nasal polyposis? Are we dealing with an invasive mycosis in a patient with a lung tumor? Are we dealing with a non-infectious inflammatory disease that could explain the involvement of the nerve and therefore accounting for the presence of this symptomatology, or metastasis? You can think about it. And then the final answer was very interesting, because at the end the solution was that we were dealing with a change in also in the lung, with a very fast change in this situation that raised the suspect that the histology was not correct. And this was a simultaneous involvement of the paranasal cavities and of the lung with the Wegener granulomatosis. Wegener granulomatosis is a granulomatous disease of unknown origin, primarily involving the upper and lower respiratory tracts. It could be associated with or without glomerulonephritis and systemic vasculitis. A trigeminal neuropathy is rarely as the sole presenting sign. But we know that there are, for the American College of Rheumatology, criteria that will include the involvement of the nasal cavity, also the involvement of the lung, and then also the examination that can help you in selecting further studies, like the evaluation of the ANCA antibodies. The clinical classification is within three forms, and one is the generalized, one is the localized form without the airway and renal involvement, and another is the purely granulomatous form without the evidence of the vasculitis. And in this situation, the middle ear, the nose, and the orbit can be involved. And this is not so infrequent, because it accounts for 30% of this situation. You see other example with involvement of the tonsillar area in this patient, and the nasopharynx and the masticatory space, but also, again, perineural involvement with a low intensity. It is very important to know this, low intensity on T2, and also the orbital involvement that is present, accounting again for symptomatology. The final case is this one, very short one. CSF leak. Therefore, the patient had a study. The CSF leak was not associated with meningitis. Can you see any abnormality? Are we dealing with sphenoid sinus opacification full stop, sphenoid sinus mucocele, sphenoid sinus opacification and defect of the posterior wall? You can think about it and look at the sagittal and also at the coronal plane. Well, The answer is that we have to discard the simply answer sinus opacification because there are changes in the wall. And the changes are not on the whole wall, but rather in a very small part of the wall, particularly the posterior one. It's like something is pushing the posterior wall toward the intracranial content. If we were dealing with mucocele, there will be a global enlargement of the sphenoid sinus. Therefore, it's something else. And what to do in this case? Of course, it is MRI. Well, this is a special solution for MRI. As you can see, it is cysternography. And in this cysternography, though you have a very high signal coming from the cistern, you also have some influence from T1. Therefore, before and after contrast agent, you will see that the vascular plexus located around the Dorello canal, where you see the sixth nerve, will enhance on one side. And then you see the fluid content inside, but then you start seeing that where we had a defect, there is something like an hourglass lesion that is partially inside the sphenoid sinus and partially inside the posterior cranial fossa. Therefore, as this is a volumetric acquisition, we can change the reconstruction. We can see the sagittal plane, injected gadolinium, and see that in this situation we don't have any enhancement. We have this hourglass lesion located partially inside the sphenoid sinus and partially inside the posterior fossa. I said reconstruction, therefore in this case you have very precisely demonstration of the hourglass appearance of this lesion. And the question is this a mucocele? Probably not. But then you have to consider the fungus ball, a cystic lesion, or a malignant tumor. Yes, the lesion is not a mucocele, otherwise the whole sinus will be enlarged. Fungus ball will be hypo on all sequences. A malignant tumor, this is something not easy, but there was no enhancement, therefore this is very unlikely. Therefore we are dealing with a cystic lesion. Which lesion? Really a lesion we have to know, because using such sequences, the chance of finding a situation like this is increasing. We are dealing with the acordosis physalifera, which is a congenital hamartomatous lesion from the notochord remnant, located in the midline, in the several part of the spine, at the level of the cranium. It is typically located intradurally in the prepontine cistern, where it is attached to the dorsal surface of the clivus. Well circumscribed, okay. It could be extraaxial. It has a content which is gelatinous, demonstrating a high signal intensity on T2. There will be no enhancement. And the differential diagnosis is with the intradural chordoma that will exhibit a higher contrast enhancement or contrast enhancement, where in the acordosis there is no contrast enhancement at all, and extensive bone destruction, but also a higher T2 signal. Therefore, we can reconstruct in a different plane, but because this is very important for this surgical approach, with the endoscope you see the sixth nerve on both sides, and the acordosis, its relationship with one of the nerves that is responsible for the movement of the muscle inside the orbit. And this is a second patient with the acordosis physalifera, with a turbospinaco T2, with a T1 post-contrast, no change, and also with a cysternography show where the lesion is before contrast agent and after contrast agent. The cavernous sinus is filling by contrast agent, and you see you don't have any enhancement of the lesion. Therefore, this is the final diagnosis. Look for irregularity in the midline, like this very small spur of the clivus that will suggest this diagnosis. Thank you very much.